You know, Africa has over 1 billion people on the continent, and of that number, well, the number of persons who have access to adequate healthcare delivery is so minimal, to the extent that a lot of people have been asking the question, what exactly is Africa doing to revamp its primary healthcare system? Well, it is the conversation we started off this month of June, and we're stretching it to the east of the continent. And today, we'll be going to Zimbabwe as well as Kenya. Welcome, I'm Sulaiman. You know, African governments spend less than 1% of the total expenditure on health in the world. Now, with records of domination by acute and infectious diseases like malaria, gastrointestinal tract infections, tuberculosis, and others, the continent's healthcare system has always been asked the questions about its quality. Now, while the government of most countries have in recent time focused on the development of teaching hospitals in cities and big towns, rural communities which many Africans still live in are unable to access quality healthcare. Health systems in countries like Malawi and, to an extent, Zimbabwe depend on missions to help build and fund hospitals. Now, their presence purges the health sector of good personnel because they pay better and have a better source of encouragement for their medical staff. An internal brain drain, sort of. Now, although many African countries have tried to improve their health budgets, the new times and its conditions also pose several challenges, ask begging questions of the state of the primary health service and the quality of personnel in there. Now, today on The Square, I have two foremost African health experts. Itai Rusike, he's an executive director, Community Working Group on Health in Harare, Zimbabwe. And pretty much later, Victor Ngani will be joining me. He's a medical expert and, of course, manager critical care and health of intensive care unit in Nairobi, Kenya. Well, but for now, let's stay with our friend in Zimbabwe, Itai. Itai, good to see you, and thanks for your time, for joining us on Village Square Africa here on News Center Television.
Thank you very much, Surumani, and I'm happy, to be, on your panel this evening.
I'm happy here because we started this conversation some days ago, speaking with a lot of great experts across the continent, because it is one thing to talk about the primary health care across the continent. Now, let's start by looking at it very keenly. How important is the primary health care to the attainment of a good public health care?
Yes, I think it's important for us to appreciate that primary health care is the first defense in terms of, access to healthcare services. And it is also important to appreciate that if you look at the African demography, majority of our people in Africa, they live in rural communities. And meaning that most of them, their first port of call is the primary healthcare service, the clinic. So it is important that, African governments should invest in primary health care, because that's where the majority of the people, access, their healthcare services. And if you look at since 1978, with the Alma Ata Declaration, where there was emphasis, on revitalizing, primary healthcare services. You then look at a country like Zimbabwe, the first 10 years of our independence, we did exceptionally well in terms of the health outcome, indicators, mainly because there was a lot of investment, at primary care level. Unfortunately, what we have seen over the years has been the biggest challenge, whereby the focus has shifted, from primary health care, to curative services. A lot of our national budgets are channeled, to our hospitals, mainly to deal with the, curative health services. And as a result, we have also shortchanged, preventive health services, and in particular, the primary health care service. So even in terms of resources, there's been very little in terms of the trickle-down effect of the national resources, to the lower levels, of the healthcare services. It is also equally important to appreciate that at community level, that's where we have what we call, the community health workers. These are the cadres that have got a direct, interface with the communities. They live in the communities. They are the first even to notice if there's any health challenge within that community. But most African governments have not done enough in terms of acknowledging, in terms of recognizing and fully supporting, the community health workers.
We'll come back. Sorry, Itai. We'll come back so that we can actually stretch for a bit. I thought I saw Victor Ngani. I wanted to bring Victor Ngani here. But again, Itai, we'll come back to looking at some of the key things the African governments haven't actually been able to put in place. But quickly here, now that we're having this conversation, time was when Zimbabweans needed to depend on foreign missions for the establishment of hospitals. Take us through what exactly the situation is at the moment. Does the government still depend largely on this, or is there an intentional approach to improving the health sector?
Yes, I think as civil society, we have been in the forefront, advocating for increased domestic, resources, to health from our own national budgets. Because if you look at most African countries, you would realize that they are heavily donor dependent. Whether it's for their medicines, majority of their medicines are donor funded. You look at their HIV AIDS programs, they are donor funded, TB programs, heavily donor funded. Even if you look at the way the health system has been functioning, you would also appreciate that mission hospitals, they seem to be better funded, than say government or a local authority owned, clinics. So as a result, there's still a very high donor dependence, in most African countries in terms of, funding or supporting our healthcare services. So it is important that African governments should also prioritize, allocations, to the health sector from their national budgets. And most importantly, you would also realize that in 2001, African governments, in Abuja, they came up with the Abuja, commitment, or the Abuja Declaration, which stipulates that, African governments should allocate at least 15% of their total budget, to health. Unfortunately, almost 20 years now, after Abuja, very few African governments have been able to meet the Abuja commitment of allocating 15%, of their total budgets to health. So as a result, you do then realize that most of our, health delivery system in Africa is still very highly donor dependent, which then creates a security risk in the event that the donors, decide to leave, for any other reason. It then leaves, the public or the communities in African countries, completely exposed because of the current, donor dependence.
I think the big point you raised now, Itai, because talking about the, a country or countries on the continent is just not only in Zimbabwe. Some other countries on the continent still, seek, funding from, European or even the United States. Now, this brings us to some of the key things. Civil societies like your own group, they're concerned to ensuring that Africans and Zimbabweans, in this case, they get the best of healthcare. As you rightly put it, the primary healthcare is the first defense that anyone gets in a community. So now let's start rating some of those amenities, facilities put in place by governments across the continent, in this case Zimbabwe, to ensuring that primary health care gets actually to the people.
Yeah, I think if you look at Zimbabwe, the first 2 decades or the first decade, I think the government of Zimbabwe really, prioritized, the health sector in terms of funding, in terms of training of human resources for health, and also in terms of supporting with the, infrastructure. At independence, we only had about, 500, health facilities right across the country. But 10 years later, I think we had almost 1,600, health institutions. And the government of Zimbabwe came up with a policy that says there should be a health facility within a 10-kilometer radius. So in terms of trying to address the inequities that existed before independence, there was that deliberate, effort by the government of Zimbabwe, to build, clinics right across the country. And like I said, even came up with the, a government policy which then said there should be a health facility within a 10-kilometer radius. They also went a step further and removed user fees, at the first point of entry. So at primary care level, there were no user fees being charged, both for maternal and child health services and for those aged, 65 years and above. And all that was an effort, for the majority of the people to be able, to access, healthcare services. And in terms of doctors, the training of doctors, the training of nurses, there was a really, crash program that was carried out in those early years to make sure that there was an increase, in the number of nurses, in the number of doctors and other health professionals. And unfortunately, over the years, because of a whole lot of other factors, we then realized that some of our best trained, nurses and doctors, they started to leave, the country, going for greener pastures. Right now, you realize that we have Zimbabweans working all over the world within the region. Some have gone to South Africa, Botswana, Canada, the UK, Australia, New Zealand, because, as a country, we could not meet, the conditions of service that they were being, offered elsewhere. We also faced some challenges with the decline, in funding, to the health sector. And that also, contributed to the brain drain. And as a result, you then realize that, some Zimbabweans started to face some, catastrophic health expenditures because the public health institutions, the quality of healthcare service, it then went on a decline. So it then became a challenge for people to access services, in the public health system.
Let me come in here, Itai. Listening to you, you'll see, or I noticed that there are some form of intention, to make things get to the people. we'll get back to the, to the nitty-gritty why it hasn't actually worked. Because if you talked about the 10 meters radius or the 10 kilometers radius, talking about making it more accessible to the average Zimbabwean, that is very key, but that doesn't look like what people are getting at the moment. Good thing I can see Dr. Victor Ngani. What happened? Apologies, we just couldn't start the show with you as we would have loved to, but anyway, good to see you. And how is Nairobi tonight?
Nairobi is good, Suleiman. Thank you very much, and apologies that I was joining a bit late. Actually, it's highly related to this COVID surge that we are in, and I had to see a patient just before jumping into this show. I'm actually, if you notice, I'm in a different place. I've requested the hospital where I am to allow me to just set up and have this presentation with you, but I'm happy and good to join you. Thank you very much, Suleiman.
Thank you for your time. And Itai has been speaking with us from Zimbabwe, and so we didn't actually lose much of the talking time. Now quickly here, Dr. Ngani, Itai who has actually told us how important the primary healthcare, system or sector is to the African, more like your first port of call. Tell us, are there things the continent isn't getting right in actually getting this, up? Because we had some other Nigerian doctors who were on the square last week, still looking at the primary health sector. Listening to Itai, who is in Zimbabwe, in Harare at the moment, it would seem as if, the problems in Nigeria is almost the same in Zimbabwe. Is Kenya any different?
Well, I may have missed what was said earlier, but I wouldn't expect that you're very different. You see, to a large extent, I think we are lagging behind in understanding that proper healthcare is a driving factor in improving our economies. If you begin to look at investments in healthcare as investments, not just expenditure, then we will focus in making this work. At the same way, we can put billions of shillings or billions of dollars into road infrastructure projects. If we understood that healthcare investment, this is investment in the people, and that a healthy people is more productive, that when people are healthy, we lose less man hours, that in fact, economies that develop and that grow are founded on strong understanding that healthcare is important. Unless you do that, then we will lag behind. So I'd expect that the same challenges we face in Kenya today, where there's a huge disparity, huge inequity in healthcare, in access to healthcare, where there's the city of Nairobi, for example, you have facilities that can actually take care of somebody, but then as you go further out, then it's much more difficult. And even within Nairobi itself, there is significant both inequality and iniquity, because if you have resources, if you are better off, then you have greater access to healthcare. And we talk about three sort of factors that come into play: the ability to pay, financial power. Then you talk about power in terms of political persuasion, and perhaps then the prestige. If you have those, then your access to healthcare is a little bit more pronounced. And so just this last weekend, Suleiman, I traveled up country. My village is about 350 kilometers from Nairobi, and you can't imagine the difference in care it's shocking. I found a gentleman who had a HB. This is the blood level of 3. For an adult male, it should be between 14 and 16, and he's almost dying. And it's because of the spleen, and it's something pretty straightforward that if you were with me in Nairobi, you could solve it. But he's almost dying in his home because we have not set up the structures that can work. And this is an issue to be addressed by primary healthcare. He doesn't need a specialist. He just needs a doctor who can be their general doctor and understand this problem and address it. Unfortunately, that priority hasn't been set, and it hasn't worked for us as a people.
Before we go back to Itai, let me bring this quickly to you, Dr. Ngani, because listening to you, one thing is clear. Every African comes from a village, and I can imagine the pain looking back, seeing our people who are in the rural areas not getting adequate health care. For instance, in Nigeria, there is a scheme after college, after university, the National Youth Service Corps, NYSC. it is only these people who are medical doctors that are sent to the villages. Once the 1 year service is over, they all also leave the villages. How can we get doctors, experts like yourself and others, stay with our people, as much as possible, care for them? Now, this looks like a government policy, is it?
Well, it is, but my experience in Kenya is that it's more than a government policy, and actually it is a government policy. But for that policy change to happen, there has to be political persuasion from the citizenry itself. The politician alone will not care about health. This is my experience, unfortunately, unless the citizens care about health. And how do we care about health? Let healthcare be an agenda in our political discussions. I'll give the example, and Suleiman, it may not be known that I was the founding chairman of the Doctors Union. And back then in 2011, when we founded the union, we had the same problem. Kenya was training doctors, but more than the doctors we trained were leaving. In 1999, Kenya had 3,000 doctors. And then we trained about 1,200 doctors in the next 10 years. But then in 2011, we only had 2,300, meaning that of the 3,000 we had, we lost 700, and everybody else whom we trained. Africa as a continent was losing more than 52% of its doctors to Europe, countries that already have doctors. Our doctor-to-patient ratio was terrible. We were short of about 40,000 doctors as a country, and yet we were losing doctors to other countries. And what were the factors? And we found it was twofold. The first was that remuneration wasn't where it's supposed to be. My salary as a doctor starting out was about $500. And $500, the cost of life, cost of living, the expectation in society is tremendous. People believe that you're a doctor and you can do things, but with $500 a month, you can barely make ends meet. Rent alone in Nairobi is more than 60% of that. And so that was one factor. The second factor was, if you work in the private sector, you have access to equipment, you can make a decision, you can test a patient. Within hours, you can make a difference. But back in the village, brilliant as you may be, you have no resources to make a difference. And so we founded this union on the pillar of trying to, improve the welfare of doctors, improve the salaries, and also ensure that the facilities work, so that even when I'm there, my expertise makes sense. And I think for about 4 or 5 years, we actually made tremendous progress. Suddenly, we were able to reverse that brain drain, and doctors in the public sector were, the numbers grew to a point where today, Suleiman, in Kenya, we have unemployed doctors. It's the government which has said that they are not able to employ everybody because of the wage bill. And this is where my conversation comes back again. It's not, investing in healthcare is not an expense. Until such a time that a country like Kenya has over 25,000 doctors, we begin to have these conversations around the cost of care. And that shift is what is needed to understand that putting doctors in our facilities, putting equipment there, that is beneficial to the economy. It grows the economy significantly. Suleiman, that's what I'd say about your question.
No, we'll come back to you, because it will seem as if you were here, even though you weren't, when Itai said the same thing. He was concerned. He said a whole lot of experts in Zimbabwe have all gone. Specifically, he said places like Canada, Europe, and of course even some to the United States. So Itai, we'll come back to you now. You work to, assist in experts like Dr. Ngani, ensure that the health delivery gets actually to the people and is up to a minimum level. What are those other things you encounter, you and your group in Zimbabwe, in helping make sure that health gets to everyone, especially those in the rural areas?
Yes, I think, for most African countries, COVID-19 has been, a wake-up call. And COVID-19 has reminded us of the importance of, a strong, primary healthcare, system. And what then happens when a country has got a weak, public, primary healthcare system which cannot withstand, the shocks of an emergency like COVID-19. Some of the things that we see, when you have got strong primary healthcare, is that there's community ownership, and when there's community ownership, there's also active, participation and informed participation of the communities. And when there is informed community participation, there's also enhanced healthy governance, because communities would appreciate and have ownership of their health services. They can even contribute resources. We have seen it here in Zimbabwe, where communities can pool resources to support their health facilities, because they feel like they are part of the health system. They have ownership of the processes that happens also at a healthy facility. And it helps also in social participation and also accountability. We have been hearing so many stories of COVID-19 materials disappearing and corruption associated with even procurement of COVID-19 materials, because there will be a weak participation of the communities. So for us, we are an organization that is deeply rooted in the community. And over the years, we have been investing a lot in terms of strengthening structures, for community participation. And when we compare health facilities where there's active, community involvement, where there's active, community participation, and where there's community ownership, comparing with another facility where there's, a weaker structure for community involvement, you would see there's a marked difference, both in terms of communication, in terms of information flow, in terms of how, the quality of care and how grievances are also handled. So for us, we have realized that, putting the people at the center of primary healthcare will really help, in terms of healthcare delivery within, our health facilities, especially at primary healthcare. And like I said earlier on, there's this stronger, primary healthcare, in rural areas, if we are to compare with urban, health facilities or urban communities, mainly because people in rural areas are very much involved, in the health delivery services because of, the various structures that exist within our health institutions, as compared to people in urban areas who are busy trying to make a living, and most of them are not really, keen to participate, in health delivery services.
Let me jump in here. Thank you, Itai. I'm also happy that you brought in the perspective of COVID-19 and some of the concerns Africans are having concerning, facilities meant for especially those indigent Africans and those in rural communities. Let me come quickly to Dr. Ngani. Some experts like yourself believe that Africans cannot afford quality health care because it's expensive for the government. That's how some experts, call them politicians, or let's use the word out there on the street, big people. They think that is not really affordable for a lot of people. Not realistically speaking, what do you think is the possibility? Is that the possibility of having an affordable primary health care service with good service delivery for the continent?
Suleiman, and I'm glad you've asked that question, and the answer is an outright and a big yes. It's more than possible to achieve that. I've had the privilege of working in different setups, government, then high-cost private hospitals and low-cost private hospitals. And I have seen facilities that are giving fantastic care far out in the rural area, and they're able to give the care that they're giving within what the National Social Insurance Scheme is able to give. And that has opened my eyes to the possibility that within the resources we have, we can actually do much better in terms of healthcare. What is lacking, and actually a couple of things, and Dr. mentioned this quite aptly, because in Kenya, what we've noticed is that a private developer can put up a very good facility for about $5 million US. And if you had to put up the same facility under a government project, you're probably going to spend 10 times that. You're talking about $50 million. And the same situation obtains in every part of this chain, whether it's purchase of drugs, whether it's purchase of supplies, whether it's a placement of equipment. And if you can run our facilities efficiently, the same way we do in the private sector, we can do much better. There is nothing unique that's being done in private hospitals that cannot be done in public hospitals. If you look at the example of Kenya, the National Social Insurance Scheme, NHIF, in 2017, it was its best year in terms of coverage. They were able to enlist anyone who wanted surgery under the scheme to undergo surgery in any facility. They were able to take care of open heart surgery for any patient who required this. They introduced schemes that allowed mothers to deliver in facilities under the care of healthcare workers. You walk in and you walk out in many facilities across this country. These are examples that these systems can work. The notion that healthcare is too expensive for government is a false notion. Yes, there must be contribution from the community in terms of paying a small amount of money, but you can actually get much better healthcare than what we have. Another very good example, right now, the leading center in terms of dialysis, in terms of transplant of kidneys in Kenya, is the Moi Teaching and Referral Hospital, which is a government facility. And in fact, if you have NHIF, which is the National Insurance Scheme, for which one is paying $5 a month per family, you're able to get a full transplant. You can get 2 dialysis sessions every two times in a week. And these are examples of successes. But what is needed is excellent political will and good corporate governance. And the first thing you have to get rid of is corruption. And unfortunately, this cuts both sides. We have healthcare workers who are on the payroll but don't turn up in the place of work. That's the reality. And then we have policymakers who don't understand the loss that it is to have more than 2,000 doctors sitting out unemployed right now while a mother is bleeding to death in a place where just a simple intervention could make a difference. This is a sad reality.
Well, we'll take a moment. When we come back, we'll just keep talking about some of those key solutions as highlighted by both of you, especially talk about what the government needs to do, what the health experts also need to do, and even if there is any need for the community to weigh in into helping make sure that this does work. We'll check all of that. That's when we return. Join us again. Welcome back. It's our home run here on VSA, talking about the primary healthcare sector on the continent. But by the way, the concept of the primary healthcare was established to act as the first point of contact of a patient to well-being. Now, in situations where they can't help, they have referral policies that make such patients move to secondary health centers and tertiary centers. Now, in Africa today, while there is an impressive influx of foreign medical companies, they come at a cost. The cost of expensive service and an unwillingness to improve the public health sector is something that a lot of people on the continent will have to contend with. Africa has thousands of rural communities and must begin to include the dwellers of those communities in medical programs, as this will be of benefit to the people. As I say, it takes a village. I still have with me Dr. Victor Ngani, Manager Critical Care and Head of Intensive Care Unit, Nairobi in Kenya. And of course, Itai Rusike. He is the Executive Director of Community Working Group on Health in Harare, Zimbabwe. Gentlemen, good to know that you have given your time to this all-important talk this evening. Quickly, let's go to Harare. Itai, before we went on the break, we listened to Dr. Victor Ngani, and it would seem as it was first a bleak one, but he's been able to raise hopes. And now let's start talking about some of the key things that will help Africa get going in terms of health. Now, the funding of majority of these primary healthcare centers come from, in some places like Nigeria, from the state governments, sometimes the national governments. Now, how can private companies, Itai, help improve the primary healthcare centers?
Yes, the private sector has a very critical role to play because they've got the resources, financial. Sometimes they can also bring in the technical expertise to support, the public health sector. But it also has to be done with some element of caution, because some of the people in the private sector are always driven, by the issue of profit, and they have to appreciate that when they invest resources, in the health sector, those resources or the services should be made, accessible, to majority of the people. What we are seeing here in Zimbabwe right now is a situation whereby less than 10% of the population have got some safety net in the form of medical, aid insurance. Because unlike maybe countries like Ghana and some other, countries like Rwanda, where there's a national health insurance, here in Zimbabwe, we do not have a national health insurance. So we have a situation whereby more than 90% of the population do not have any safety net at all, meaning that they have to depend, on a public health delivery system. They cannot afford, the catastrophic, health expenditures that we see, say in the private, health, sector. So yes, we have seen it being done elsewhere, where the private sector can bring in technology, the private sector can bring in financial resources, the private sector can also bring in, the technical expertise, into the public health delivery, services. But like I said, it also has to be done in the sense of also protecting the majority of the poor people who may not be able to then, afford to pay the huge, user fees that are charged, say, in the private health sector.
Let me bring in Dr. Victor. You recall it was Itai who mentioned COVID, and it got me thinking, there are rising emerging and even re-emerging diseases, and we don't know when these problems will rise again. Do you think the continent, or rather what can the continent do to make it more prepared just in case there is a re-emerging disease or epidemic?
Suleiman, before I get to this particular question, and if I skip it, please remind me, allow me to just talk on this matter of investment and the role of the private sector.
Oh, by all means, go ahead.
The private sector has a big role to play, and there's a public-private partnerships that must come into play. But I feel that as African citizens, we are letting our governments off easy. The truth is that the private sector, no private entity, is able to out-invest the government in healthcare. It's not possible. The government can do a lot more and more affordably. What we are lacking is efficiency in management of resources. We are not efficient. We are wasteful. We allow corruption to thrive. You see the choices of leaders that you've had, for example, in many African countries, are cronies and friends, people who are aligned politically, which is different from the most effective leaders. I've suggested in some forums that in healthcare, as in many areas, we need a PAIVA leader. PAIVA is an acronym for someone with a passion to, make healthcare better, a person with integrity, because that's a key thing that's holding us back. A vision to understand, to see that it's possible to have the best facilities in the country being public facilities, and then the ability. So if we are able to get such leaders in places of authority, we could see a dramatic difference in where we are heading to. That said, these diseases that are coming up should have opened our eyes. And Suleiman, on this very show, I mentioned that the biggest tragedy is that we had a year to prepare and we didn't do it. Right now in Kenya, earlier on we had surges and crises affecting the major cities, and it was pretty bad. But then these are the cities where we have some level of healthcare. We have the biggest hospitals are here. They're pretty high level, to be honest. The hospitals that can do open up surgeries, neurosurgery, multiple specialists already in place. But then lately what we are seeing is that far-flung counties that don't have as much resources or as much capacity as these main centers are experiencing surges. And just today, the reports you're getting is that it's pretty bad, and it's just getting worse. The lesson from India is a lesson that we should be alive to as a continent and begin to prepare, because it's not in the far future. This is with us right now. We are staring at a tragedy that's facing us, and we must increase our capacity, number one, to live with conditions like this. Basic concepts like vaccination. India is making its own vaccines. When India says you're not going to export vaccines, we are almost crumbling. We are pleading, why can't we make our own vaccines? What lesson have we learned? What can India do that we cannot do? What can an Indian do that an African cannot do? Let us build our primary healthcare centers. And primary healthcare doesn't require specialists, general doctors, the nurses. Let's mop up all these resources. Why should we train a doctor in Kenya or in Zimbabwe or in Nigeria and let this doctor go to another country? What is it that the Western country knows that you don't know, that they willingly embrace these brains that we've created and allow them to treat their people? Right now, there are big campaigns to attract African nurses to Western countries. Why can't we see the wisdom in these processes? And I think if we just change that mindset to a small degree and then link PAIVA leaders to healthcare leadership, and we as citizenry become concerned about healthcare, that before I vote for somebody, ask you this question: what will you do for my health? We will not make much progress. But if on the converse, we do all these things, then the future is bright. And unfortunately, for something like COVID-19, I feel it's pretty late. The interventions are limited. We could try and get vaccines to our people. There's a lot of hope in that direction. It's not a full guarantee, but we can try and do that. And then look back to this season as a learning point and strengthen our public primary healthcare structures. Please, leaders across board, let's do this. Let's do this.
So I'll come back to you, because this is a painful reality for the continent, this conversation we're having. Itai, listening to Dr. Victor, he's also touched on what you earlier mentioned. There's a brain drain from the health sector, especially in Africa, and the reasons are not far-fetched. Kenyan doctors went on strike recently, and of course the same thing we saw with the Zimbabwean health workers. They went on strike this year too, and same thing in Nigeria, South Africa. So is this a public health challenge on its own, Itai?
Yes, if you look at, before COVID-19, our political leadership would go outside the country to seek for healthcare services. Even for minor ailments, it was very common to see, African leaders flying to Singapore, Malaysia, China, the UK, and so forth, to go and seek for medical, care services in those countries. But because of COVID-19 and because of the travel restrictions, those African leaders, and most of them are not able to travel, outside the country, meaning that they have to seek for healthcare services within the country. Unfortunately, they are now going into the health institutions and being served by those underpaid and undervalued, healthcare workers. They are now going into those institutions which are, poorly equipped. Those institutions which are having, constant, spouts of medicines. I think it is important that African, governments should value and respect, their, own health workers. It is very expensive to train a nurse. It is very expensive to train a doctor using taxpayers' money. And then at the end of the day, that same doctor then leaves to go and serve, people in the UK, people in Australia. And in most cases, there are no compensation even paid to say the government of Zimbabwe for training that doctor, for training that nurse. But we are putting so many push factors, and these push factors are the ones that are forcing our well-trained, health workers to leave and go and serve, the citizens of other countries who did not contribute anything, in the training of that nurse, who did not contribute anything in the training of that doctor. But at the end of the day, they are the ones who are then benefiting, from all the investment that would have been put, in training those, nurses and doctors. So I think it is important that our African governments, like I said earlier on, they need to value, they need to appreciate, they need to respect their own healthcare workers. Because what we see in so many cases is that when we bring expatriates coming from those other countries, their conditions of service are totally different from what we are paying our own doctors. Would rather take care of the expatriates, who are coming from those rich countries, and we give them better conditions of service than our own doctors. Sometimes it's not just about money. Like you said, in Zimbabwe, we have been having, doctors going on strike sometimes 3 times a year, sometimes 4 times a year. Last time they were on strike for about 78 days, and leaving patients without any care at all. But in terms of then responding to the concerns of the doctors, to the concerns of the nurses, we are not also coming up with long-term solutions, to address the grievances of those nurses and doctors. So we as an organization, last time when the doctors went on strike, we were requested to, to mediate. And as we were mediating, we also offered, the other non-cash incentives, that the government could also, give to the doctors, because the government was saying they did not have, enough resources, to meet like the regional, conditions of service that, fellow doctors in other countries in SADC region, were getting. And we said, why don't you extend like a duty-free facility whereby a doctor is able to bring a car to Zimbabwe duty-free? Why also not extend, like residential stands for doctors?
I get the point. Talking about, sorry to cut you there because we're running off, and I wanted Dr. Victor to also to close this for us. I get the point, Itai, because we're talking about incentives, talking about things that will make the doctor on the continent stay back. And of course, you also talk about the disparity in emolument, in payment, in services, in the contract between the African health expert and the non-African health experts. So what's the solution to some of these problems? I want you to quickly react to some of the things Itai said and quickly talk about the solutions, if you can do that quickly so that we can wrap up. Dr. Victor.
Well, Suleiman, it's something I've already mentioned, and this is basically changing focus. And the sad example I will give, perhaps allow me to just give three such examples. A mother dying at 35 during childbirth, preventably. Can you imagine the poverty that plunges that mother's other children into, and the husband? Imagine a young man in his prime, 30s or 40s, dying of something preventable like malaria, really that is curable, and even prevent at this time. You can imagine the impact if that's a sole breadwinner. And this is not a hypothetical case, it's what happens every single time. Now, marry that to a situation where someone says, a country like Kenya that's now approaching 50 million inhabitants, 9,000 doctors, someone could imagine these are too many doctors for us to employ. Or to say that let's pursue a strategy that targets the unions, because I remember our own strike in 2011. We had traveled every single TV station for 9 months and nobody listened. And there's a strike. And until we change that focus, until we change that mindset to understand that no, 9,000 is drop, 50,000 nurses is too little, that any mother dying is an issue, any young man in their prime dying increase our dependency ratio, that these are economic factors, these are drivers of poverty. Until we change that, we're in trouble. So Suleiman, to answer that question, is for us to move away from what I call nose length thinking. We are looking at the future, but no further than our noses, and those noses are really African noses, which are not very far ahead. And we need to change that and look beyond the corner and begin to make decisions that are prudent for this continent.
Well, I think it's a fine place for us to leave it, but I must say our conversation today has left a sour taste in the mouth of every African. It's something every African must be bothered about. Community involvement at this point in primary health is cost effective, no doubt, as we've seen. Individuals are easily identified and problems are better scattered. So why would any government ignore or look the other way and not fix what should be fixed? Primary health care in Africa can be improved upon, as Dr. Victor and Itai have both highlighted, and that's the message on The Square today. So thank you again for being such nice company, Itai Rusike from Zimbabwe and Dr. Victor Ngani. Against all odds, you were able to log on. Many thanks. We appreciate your time. And of course, to our viewers across the continent, thanks for watching and staying in The Square. See you again tomorrow. Bye-bye.